The floating labrum, Bankart lesion repair with anterior capsular extension using 2 anterior working portals. The patient is a 16-year-old gentleman who sustained a first-time dislocation of his left shoulder approximately 2 months prior to presentation while playing football. This dislocation spontaneously reduced at that time. He presented to clinic where X-ray imaging was taken, which showed evidence of a Hill-Sachs fracture. An MRI was also obtained, which showed evidence of a Bankart tear of the anterior-inferior labrum. A lengthy discussion was had with the patient at this time. However, he chose to return to football to end the season wearing a Sully brace. He returned for surgery approximately 2 months later at the end of his football season. The patient was taken to the operating room and placed in a lateral decubitus position using a traction arm holder. Examination under anesthesia was performed, revealing grade 3+ shift in the anterior superior, anterior middle, and anterior inferior directions under load. There was also a grade 1+ posterior translation with the load and shift test. A standard posterior viewing portal was established, followed by the establishment of an anterior-inferior rotator interval portal via an outside-in spinal needle technique. Diagnostic arthroscopy was notable for intact cartilage surface of the glenohumeral head. The labrum was inspected. There was a Bankart tear noted from the 6 o'clock to 12 o'clock position. The posterior labrum was found to be intact. Additionally, the anterior-inferior and posterior-inferior capsular structures were well attached down to the humerus. Importantly, we note from this that there's both a Bankart tear as well as a capsular split. Therefore, the capsule is torn and needs to be addressed in addition to the labrum. This unique pattern was a variant in which the labrum was torn off the bone, but also the capsule more anteriorly, demonstrating a floating labrum. Viewing posteriorly, the anterior-inferior interval portal and additional anterior-superior portal were utilized to allow for both the grasper and suture passer to work in the same area. Attention was then turned to the glenoid neck. This area was debrided to a light bleeding surface to promote healing. A total of 5 1.7 suture-fixed anchors were then placed at the articular margin edge. The sutures were then passed using an AccuPass suture passer in a single fashion around the labrum while also incorporating them into the split in the capsule. Care was taken to shift the capsule superiorly. The labrum was fixed progressively from inferior to superior, achieving both a labral repair and capsular shift implication with the suture anchors. Once the labrum and capsule were prepared, the head was now centered from anterior to posterior. The arm was taken down and a repeat examination under anesthesia was performed. The shoulder was now stable to load and shift testing in all directions, including anterior, superior, anterior middle, anterior inferior, and posteriorly. Note that as the final anchors are being placed superiorly on the glenoid, the middle glenohumeral ligament is nicely retensioned to provide stability to the joint. Now that the defect is all repaired, we can see that the IGHL and MGHL were also retensioned. Therefore, the capsular tear was also addressed while the labrum was repaired. Postoperatively, the patient was placed into an ultrasling with instructions to avoid combined external rotation and abduction.